I do see some familiar friends and partners. Huang, who's our director of Office of Health Informatics at Wisconsin DHS. So you'll see some of the partnership work we're doing in the end. But this is a talk that will go in kind of two stages, given the time. The one is what we've built for healthcare kind of delivery in our health system as an AI application, but then using that same kind of software in kind of a public health setting as well, and some of the kind of more developmental work that we're doing with our state partners. And so the substance misuse algorithm for further treatment using AI, smart AI, is our system that we uh, is a bespoke model that we brought into application. Now, before I start the talk, I think there's a huge gap that I think you guys have recognized between building prediction models, training prediction models, using frontier models. These are pretty much now pretty mature out of the box, and there's a lot of packages that are easy to deploy, as novice programmers can do. But then going from prediction model to clinical decision support is a very separate process. And that translation is a huge gap. And that's the leaky pipe I'm showing you here, as a lot of these models never even make it to production. In fact, if you look at literature, it's like less than 1%. And I always think of the 5 rights of clinical decision support. You got to get the right information to the right person in the right format through the right channel at the right time. And so that's a lot of the human factors and systems engineering work that goes into AI applications that really a lot of them, especially for healthcare delivery, aren't just plug and play. So let's talk about the problem use case here. So we're talking about screening for opioid misuse. And USPSTF, as you guys know, has a grade B recommendation for screening in adults. Currently, these are validated survey instruments that are manually administered. The TAPS is one of them, the drug abuse screening tool, the audit, the alcohol use disorders identification tool. As you guys know, the TAPS has a first initial universal screen to identify any risk, and then kind of risk stratifies level of risk beyond that, so that folks can go on to make a diagnosis of a substance use disorder. There's no formal screening program currently at University of Wisconsin, or there wasn't for hospitalized adults with at risk for opioid use disorder. We do have alcohol use disorder screening because that's part of our level 1 trauma credentialing. But we still are asking these questions. It's part of our intakes. It's part of the documentation we capture. It's our social history that we're trained in medical school and healthcare schools to kind of ask these questions, but we don't actually use those data in the notes. Regardless, this is still a major problem. A lot of our hospitalizations are substance use related, not overtly just from overdose events, but actually physical ailments, endocarditis, wound infection, sepsis, asthma, pneumonias. Actually, we see a lot more of those. And these are individuals who are, develop these conditions as an underlying risk from their substance use disorder. So all that being said, is can we leverage the data in the electronic health record? And so our work has been focused on the inpatient adult setting. I'm a critical care doc. I'm a physician scientist, and I practice in the inpatient setting. So that's why my focus is there. Now, we looked at the first 24 hours of notes as kind of the training data, or the data source to work off of, because average hospital stay is about 3 to 4 days. So if you can get the screening identification done the first day, then you can start the treatment intervention subsequent to that and have time to do it. Documentation wise, 97% of these notes actually have some mention about around substance use. It's kind of just routinely done, but it's nowhere leveraged. And given that the EHR is over 80% documentation notes, you can imagine it's a powerful source of information. So what does that look like? Many different note types. Those of you who are familiar with electronic health record, there's progress notes, admission notes, consult notes, social work notes, nursing notes, so on and so forth. And any one of these given notes that are listed here among the note types that are in our health system, you can see that there's examples of substance use hidden in the history of present illness, in the social history. Things just as simple as mentioning the substance use type, or overtly saying heroin use, or saying or just risk factors for substance use that may be related. Now, how do we process these notes? So LLMs are very good now at kind of just taking it, and you can give instruction, but there are a little bit more kind of nuanced approaches given the prior natural language processing methods. And so we kind of followed a little bit more of a modular architecture. In this case, we followed the UEM architecture, which is what IBM Watson is built off of. And essentially, it goes in through these kind of modular annotations where it takes a given note corpus and can break it down into sentence level, and then down to kind of token level, and then it can disambiguate between the different negation and non-negating kind of terms. And so there are a lot of different NLP engines out there, and we use an open source one called CTAKes. It's the clinical text and knowledge extraction system, which has been around since like 2010. I think it was originally developed out of Mayo. And part of the kind of annotating or the kind of modular process in this NLP engine, it kind of goes through these sequence of events. The last kind of step is once it's done kind of the whole parsing and kind of work to kind of organize that unstructured data, is that we can do concept mapping. We can actually take span entity mentions like, a given set of, 3 or 4 words at a time, what's called trigrams or bigrams or 3 tokens, and actually map them to concept codes from the National Library of Medicine. So imagine in this case, we have concept codes that are mapped to opioid misuse or prescription opioid use or heroin use or anything, myocardial infarction. And so there's a whole meta thesaurus around these different ontologies. And you guys know these ontologies, ICD codes, RX norm, LOINC, SNOMED. And so all these actually can in a taxonomy can go up to what's called a concept unique identifier, a CUI. So a given CUI, which is shown here, will have all the different atoms that stem from an ICD or an RX norm or a SNOMED. And so we're actually working at the CUI level as I continue the conversation. So the workflow then is like you come in, you get a set of notes. We actually will take all the notes, regardless of note type, and concatenate them, feed them into the NLP engine, and out comes these coded concepts. So it's actually a little bit of a transformation, of feature engineering, we could say, on the notes themselves to get them into a more structured format for the type of process that we use here. And so we did the initial work that we published in Lancet Digital Health to kind of show, we went to a health system that was manually screening using the DAST and audit. So they were one of the few health systems in the country at the time. This was at Rush University in Chicago. They had screeners and a whole program built around every adult that came in got screened using these validated instruments. So you can imagine the human labor needed for that, but it was great training data, right? Like this was 3 years, over 80,000 patients that were hospitalized. And so we had validated instruments that served as our reference labels, the gold standard that we would train against when we do supervised learning for machine learning activities. And so this was, like I said, we focused on the training data. Then we had the instruments kind of label, identify folks that were screen positive and screen negatives. And then we took all the notes, which was a separate location in the EHR from the first 24 hours. And that QR code there will take you to the website, the GitLab. Actually, we share the trained model that we trained, and I'll tell you how we were able to do that. But the idea then here is we did the feature engineering, right? These are the CUIs. They're trained in a supervised fashion against those validated survey labels of yes, no's. So we had a training set and a development set and then a holdout test set. And then the model, one single model, can give us 3 different labels for a given patient: opioid misuse, alcohol misuse, and non-opioid misuse. So this is a screen would actually screen positive, identify folks that you would then want to go and perform diagnosis on. So you have a note and maybe has these random mentions: asthma, inhale, injection. All these get mapped to a concept unique identifier, CUI code. So I got a string of CUIs. These CUIs, you could think of them as tokens, right, for an LLM. But in this case, we're not doing an LLM. We're doing a pre-trained, it's kind of a supervised training model against those labels. In this case, it's a convolutional neural network that we trained. It was a CNN. And so this was a multi-label CNN. It was a kind of a shallow CNN where each CUI was kind of the filter size for that neural network. And all these CUIs were kind of, 50,000. It was a vocabulary of about 50,000 CUIs. So it's, LLMs have vocabularies of somewhere like GPT-4, I think spans around 125,000 subwords. And so our vocabulary was just on the medical concepts that were in our distribution of 50,000. And then the final model had about 13 million parameters, which is much smaller than the multi-billion parameter LLMs today. Now we did this and we tested it on a holdout test set that was the most recent set of cases at that hospital, as well as taking it to a separate hospital system and testing on their patient population with the trained model. And you can see that the precision of recall, which is one measure of discrimination of telling cases from non-cases, the AUROC, or CRP characteristic curve, is another way of looking at this. Really good kind of scores when we're doing this testing on these different cohorts. And for the opioid screener that we were going to implement at our health system, when we think of screening tests, we really want something with good sensitivity. We don't want to miss cases. We want few false negatives. And so that's where the sensitivity of 87%, along with acceptable characteristics across the other test metrics, were really good for this one. So with those numbers, then we kind of go to our workforce and look, The number needed to evaluate was 1.3, meaning for every 1.3 patients that the classifier identified, one patient was a true positive for screening, which is really, for our needs, it met the purpose of the workup to detection ratio we wanted. And in fact, when we looked at our hospital census, it came out to about 26 alerts per 1,000 patients, because you want to avoid alarm fatigue in these folks too. The next thing we want to look at is calibration. What's the absolute risk? Regardless of discriminating between cases and non-cases, we want to actually see, does the prediction match the observed probability that we were seeing, the observed cases? And so this is a calibration plot. The middle line is kind of perfect calibrated, meaning a slope of 1, intercept of 0. Our model, you can see, is a dotted version of that. It's almost kind of like really good calibrated. That p-value being non-significant is because we fail to reject that it's different than a perfect calibration. So that's actually a good thing. Next thing we looked at was kind of like fairness metrics. How does a model perform across different subgroups? Because we certainly don't want to be stigmatizing one group with more false positives and kind of labeling them when they shouldn't be, right? And so we looked at non-Hispanic Blacks, non-Hispanic whites. We looked across multiple races and ethnicity groups. We also looked at area deprivation indices by groupings as well. But I'm just showing you here some of the false positive and false negative rates comparing non-Hispanic Blacks and non-Hispanic whites. And it was acceptable in terms of like the performance of the model across these different parity groups. And then we also wanted to know what were the main features in the model, because obviously, like you guys are wanting to know, is explainability of these black boxes. And so we use some explainability algorithms. I'm not going into details here. The one for this one is called LIME. And you can see the mentions, these text spans of the CUI codes in their preferred text that relates to that code. Makes sense in terms of what you would expect to see for a model that was trained on the data for identifying opioid misuse. This is another way, and I think this is similar to the OML trace, tracing the language model outputs. This is called integrated gradients. It actually it's Facebook's version of that, and how to do this. But essentially, you're looking at across the layers, comparing to a randomly kind of generated model of CUIs that would have no sensical relationship to each other. How does your model compare to that baseline model? And that's an attribution score that you look at. So then you can actually see across each token or each CUI, what is its contribution to the final prediction of the label 0-1 for opioid misuse. In this case, the red light ups are things that given that text above being transformed to the CUIs below, the heat map of like where the things that are lighting up from the model's interpretation of what's significant. So we've built the model, we did that first paper, and the next step was, okay, how do we actually now take this bespoke model and put it into practice, into a complicated health system with the EHR? And so this figure shows you the second paper that we did is kind of how we protocolize this into practice. And so we're an Epic shop at UW, and so we have our on-prem Epic instance. And so in order to get real-time feed out of that, separate from our research kind of database, we had to use HL7, Health Level 7, to do an interface out into Cloverleaf, which is kind of a data exchange platform that then organizes those notes and all the metadata that we need with it. And we run an Azure shop. So we're an Azure cloud system for our health system as well as our research enterprise. And so this goes up into Azure, into our Databricks environment, which is kind of the ML kind of infrastructure. Within that, we have a data lake where we store all these things. And so here, then we can do the NLP processing that I talked about earlier, the CTX engine, to then do that kind of CUI transformation. And then it feeds into our trained model, the 15 million parameter model that's already been trained. It just feeds it and does inference and spits out the probabilities for each of those labels on each of those patients. And we have a threshold cut point on at what point do we decide that it's a screen positive versus a screen negative. Screen positives then go back out into HTTPS call, and we set up a NetScaler gateway for be able to kind of have some control over this from our cloud to Epic's cloud, because this is the only way we can bring it back on-prem. So then from going through Epic's cloud, then we were able to bring it back on-prem. And now once it's back on-prem, we can populate it into any kind of structure within Epic. It could be a flow sheet item. It could be any documentation item, whatever you want to do it. In our case, we did a best practice alert. So we went to a flow sheet and for screen positive. And from there, we were able to build this BPA. So what happens in practice is that you're an ED doc, you're a hospitalist, you show up to practice and you're seeing a patient and you you open their chart and this alert pops up. Doesn't matter who opens a chart, any provider that goes and opens a chart will get this alert. The alert tells you, look, this patient may be at risk based on what we saw in the documentation. Two things that you can do now. You can order an addiction medicine consult, or we have an inpatient service that can come and help you make the diagnosis and potentially initiate treatment, do harm reduction services, connection to outpatient care, SBIRT, whatever is appropriate. In addition, based on some of the feedback we had, they also wanted to putting in the clinical opioid withdrawal scale because a lot of our patients are not treated appropriately and are starting to experience withdrawal and leave and before they can get the right treatment. So the clinical opioid withdrawal scale is then automatically ordered as well to start at least monitoring for that in case they develop withdrawal symptoms. And then you can also pick reasons why you didn't want to do this so that we can track it for our research purposes. And then within that, these are the reasons that you can go into. So there was a whole clinical operations workflow to deploy this prediction model that we trained and validated on performance metrics to bring it into as a kind of a non-device clinical decision support tool. And so we had to go through governance. We have an AI governance committee in our health system. We had to go through our nurses and our hospitalists, all our kind of workflow committees, our clinical decision support committee. We brought in implementation scientists and human factors experts to kind of do some pilot testing, ensure that the feedback we're getting from end users, yes, this is useful, I would use this. We had to do some silent testing to ensure that the metrics that we saw in other health systems were similar for sensitivity and specificity in our health system. And so there are a lot of things to kind of overcome that. And then in the end, like we are continuing to monitor. Every year, this goes up for review to say, hey, is there drift in the system? Are we starting to see changes in the usage of the best practice alerts? So to review, I showed you guys some of the accuracy on the modeling itself in the initial development phases, how we determined it was fit for purpose in terms of workflow. I went to some of the calibration on absolute risk and kind of look into the model's calibration, bias and fairness metrics, explainability. We then took that, worked with our DevOps team and our health system to kind of build this into practice using HL7 interface with the EHR, which in our cloud system to then bring this out. During all this, we went ahead and registered it on clinicaltrials.gov because we were going to now move towards a clinical trial or kind of an implementation study, a pre-post design. In doing that, as I mentioned, we kind of followed this kind of implementation science workflow of doing these rapid PDSA plan, do, study, act cycles where we kind of show people the BPA and potential end users, ask them, hey, does this make sense to you? Would you use this? That's how we came up, and we talked to our addiction medicine teams. That's how we came up with the need for the cows. That's how we decided to actually start the alert, kind of the algorithm earlier than later. Even though it was trained on the first 24 hours of notes, we went ahead and started running it as soon as the first notes started populating into the system. So once we were ready, then we kind of set this up as a clinical study. And so we did this as a EHR embedded, fully EHR embedded pragmatic design. This was a quasi-experimental pre-post design with that kind of hybrid effectiveness of using implementation science. And so we had our usual care kind of pre-implementation phase across a couple of years. And then we did the seasonally matched post-implementation where pre-implementation was just, hey, you would order the addiction medicine consult if you thought of it. It was kind of ad hoc based on the provider discretion. Post-implementation phase, you had that, but then you also had the augmentation of this AI system, which would then also nudge you if it was something that you didn't think to do. And then the way we measured outcomes was we actually decided not only do we look at who received a referral to a consultation, but who actually ordered it and and then of those orders, did they go on to actually receive the consult with an intervention? So that was really the meaningful outcome that we were tracking was those who received an AI addiction medicine consult with some type of intervention. It could have been anything: medication for opioid use disorder, harm reduction, Narcan, naloxone prescription, linkage to care, SBIRT. So that's what we published most recently. That was our outcomes study that we put out in Nature Medicine. And with that, we did cost effectiveness. So in that study, we tracked all the BPAs that was alerting the individuals. It was over 4,000 BPAs across 160 hospitalizations. On median, it was 10 BPAs that were firing per patient that was screened positive. So that could have been 10 different providers opening up a chart or the same provider opening it up 10 times. It didn't matter until you actually either accepted it or dismissed it for a specific reason. Of those, 22% led to the addiction medicine consults, and only 3% were recorded as inappropriate, which kind of matched our performance metrics beforehand. And then 27% received the cows. And so this came out to be more than 10% of all the consults because you didn't need to have the BPA alert to order a consult if you wanted to. It could have been for any reason. So our primary outcome when we looked at this in terms of like the pre and post period, we weren't looking for superiority. All we were trying to show was, is this at least as good as what the humans were doing? Because if we needed to automate and scale, is this a viable solution then? The reason we say that is because, for instance, at the health system, we got all the great training data from Rush. During COVID, all their screeners went away. And since then, they haven't been rehired back. So then they didn't actually have a screening program. So this is actually a solution for that, because if it was just going to be as good as what humans were doing, at least you can automate this and not prioritize certain patients based on bias selection or things like that. Can be systematic across the system, across the health system. And the last part of this is we did a cost analysis. So to actually get this thing up and built de novo, because we hadn't done this before, we had in-house expertise to do it, but these are expensive DevOps engineers and their time. And so it cost about $350,000 to build that system I showed you earlier. And then the incremental cost that went along with that. Regardless of that, though, it actually was cost effective when we looked at the secondary outcome of 30-day readmissions. We actually saw a reduction in 30-day readmissions that was associated with this program. We didn't see it hospital-wide outside of the program. Readmissions didn't change. There were no other seasonal changes. There's no other changes in the program. It was only this piece that we saw of all those patients that received the AI referral consultations. And it was actually odds risk of 0.53. And so we are actually seeing a 6,800 kind of cost avoidance per readmission, which offsets really the cost that it took to build the program. So in kind of conclusion of like this kind of from beginning to end, from software development to software implementation and outcomes evaluation, we built this hospital-wide AI screener for opioid use disorder. It was just as effective as the healthcare provider only approach. Patients with AI screening have 47% decrease in odds of being readmitted to the hospital. And we estimate $109,000 in savings in a 6-month period. And to this date, the screener is still running live in the program. Now, the next thing is like, this is a screener, but it's also in what we call computable phenotype, right? This is an identification tool. So it can be used in other applications. And so this was one where we thought, well, like, what if we did this kind of as something for the public health system as well? And so that work was kind of trying to do a little bit more. In fact, we wanted to identify cases, but then we also wanted to kind of bring in other information about these individuals that would be useful to our health systems, our overdose fatality review boards, our public health partners. Because as you guys know, one of the biggest gaps is like there's all these great agencies and systems out there, fire, police, criminal justice, DOJ, DOC, PDMPs, and all these systems, but they don't necessarily talk to each other. And so the idea is with linkage, can we actually better identify risk in these individuals and identify kind of information that'd be useful for our stakeholders? And so with that being said, I had mentioned earlier what we did in the health system to run this as a CDS tool, which is this part of this figure, kind of briefly highlighting some of the tools and services that we built. But then what if we, on the SMPH side, also ran this tool in a data commons where we can actually bring in agency data and other health agencies information and link it in a privacy-preserving record linkage approach with the cohort that we identify from our index cases of our health system, as well as other health systems. And so we called this a substance misuse data commons. And this is what one of our colleagues, Huang, over at the director over at the Office of Health Informatics or DHS, was a great partner in helping us kind of do this proof of concept. And in this proof of concept, what we did was kind of something that's in terms of using privacy preserving record linkage. This is also what the N3C dashboard uses as the backend. For those that aren't familiar, I feel like at this point, like a lot of us have kind of come across a system like this. We use the DataVant version. But essentially, this is kind of cryptographic hashing, right? So that no PHI needs to leave your kind of secure firewall to then allow linkage across PHI identifiers, right? All you're really doing is you're building this kind of token ID, this cryptographic hash that's a representation of whatever identifiers you have. And then through this kind of encryption system, one-way tokenization, can you then also link across other stuff using this kind of de-identified version? And so we did this and we did it across multiple data sources. So we have 3 major health systems that we looked at here that were just recently got a grant funding. So we've kind of reinvigorated this project, which is why I'm talking about it now again. So we have our health system of index patients. And so this is also guys from the health system perspective, right? We're not looking at the entire population or state. We're really doing it off index cases identified at the health system. And we're doing it index cases that are identified using our smart AI computable phenotype as an cohort identification tool is the one way to think of it, as well as like ICD codes, which has been traditionally used in all the different variations of ICD codes. And I'll show you kind of differences in those. And so for each health system, then we kind of pull out all their tabular data in OMOP format. We run CTAKes to get the de-identified CUIs, which is why we can share these models, like the trained model I gave you the QR code for. The reason I can share with you is because there's no PHI in the model, right? It's trained on just these concept codes. So you do have to first transform it to use to the concept codes to use it. And then we worked with we have our kind of social indices, socioeconomic indices that we brought in. We have the prescription drug monitoring program, not the physician drug monitoring, but DHS vital statistics, the ambulance run data system through the Office of Health Informatics. As I mentioned earlier, DOC data, we get all claims payer from a one of the companies that provides that information. And then in addition to vital records, we're also getting other national mortality data using obituary feeds that are crawled with some basic NLP and Social Security Administration. And so you can see why the NLP-based system can bring you additional. This smart AI kind of helped us identify another 20% of cases. Now, for death data, the reason we use 3 different sources is that we used the death recorded in the EHR, the death from commercial death data using those obituary feed crawls, and also the Wisconsin vital records. And there was actually this difference. Obviously, vital records is kind of state limited, so we identified a lot of deaths that occurred out of state, and then the date going back. And so we actually found some bias when we didn't use all 3 of these systems. And you can see that the unmatched and matched were kind of disparate between the area deprivation index, as there was differences between these folks. For EHR systems, a lot of the payers are good at tracking death and stuff like that, but are uninsured, and others it may not be as well recorded, and so there's bias there. And then there's other things with the commercial data and the vital records data as well. So one of the use cases that we trialed out first was we did a bunch of interviews with OFR members across our counties. As you know, we have a catchment, or as I didn't mention this, but our new grant is going to have a larger catchment just from beyond our health system. We're going to include Milwaukee, Freighter Health System, and Marshfield, which is one of the largest rural health systems, to really kind of get a better representation of the state. Again, these are indexed from the health system's EHRs. Before, for example, OFR review cases were manually collated together of all the different things that happen across corrections, claims, hospitals, EMS, PDMP systems, and someone actually brought those together. So now you can imagine with our system, we actually built a synthetic data set to demonstrate this. So we actually modeled our data and use both LLMs and what's called GANs, generative adversarial networks, to build synthetic data sets that was representative of our population, so that we can share with you guys. So if you go to that QR code, we actually have a full data set for you guys to play with if you wanted. And we use Microsoft BI to build an interactive data dashboard that brought all these data sources together. And you can see how that comes, because now we can build an automated timeline of all the different events that happen that comes from across these data sources, as well as kind of a technical and timeline and details that are relevant in summarization in this thing below. And then the bottom right-hand corner is our prediction modeling. Now we're actually starting to, one of the aims of this new grant is actually build a 30-day risk for at discharge, so we know if the patient's is high risk for coming back, to intervene now versus waiting for them to come back, which is another reason separate from screening at the beginning of the hospitalization to start treatment, but start at the end of the hospitalization to identify those that may come back. Kind of finishing slides here. This is a team science approach. I think I mentioned our partners at DHS. We have peer recovery coaches here that are part of this work, patients, individuals with lived experiences. We have our addiction medicine specialists that are part of this team. We have criminal justice experts. We have ethicists. We did a lot of stakeholder interviews. We actually went to OFR teams, and we have a study that will hopefully get published soon of all the interview usability and acceptability of this dashboard, like how much cognitive burden did it reduce and things like that, to understand the benefits of it. And then obviously our state partners have been really kind of collaborative in this effort, which is a great example of an academic state partnership. So we're really grateful for that. the NIH has been really happy with this work, especially the initial kind of screening tool. They highlighted that in their last April edition for research. And this is some of just my internal lab team that also you can see we have a pretty big team of data engineers and data scientists at the PhD and master's levels. And obviously I mentioned our state partners that we've been working with. So I think that I'll stop there. I kind of wanted to highlight some of the applications of how you can use the same AI software for different purposes. And I will end by saying, so we train on high quality data, and this convolutional neural network, we're having a hard time getting an LLM to beat it. We still think there's benefits in the LLM version of this because it can multitask. Because imagine now you can not only screen, but you can guide the clinician to diagnose and initiate treatment with AI agents. Actually, that's just to be transparent, that's our renewal grant proposal is like, we're going to take an LLM version of this now and actually walk through the help to assist the providers to initiate treatment, because a lot of what we got feedback on from ED docs and hospitalists and such is that they're still just not comfortable initiating treatment for individuals with opioid use disorder, or even kind of following the DSM-5 criteria to make a valid diagnosis. So there's opportunity there with these AI agents that we are doing in our lab. Thank you.
Wow. I was so excited to hear this all laid out. Thank you so much for sharing this. I mean, the science and the engineering behind it is massive, and I appreciate that. But the thing that really sticks with me is that this is still keeping that service of, you know, the screening provided to people, you know, even in the midst of staff cuts after COVID and all. You can have that that continuity of being able to screen for opioid use disorder and getting people into treatment, and you know, the reduction in readmissions is amazing. I mean, I know that's a goal on so many different hospital and clinical measures, and it's
and cost
very
effective,
cool.
right?
Yeah, and yeah,
Just,
it saves money, saves lives, and you know, just it's my favorite kind of use case. But I know we've got folks from the clinical side, nursing side of things here. I don't want to hog the question session, so please ask away, folks.
Yeah, I see a question in chat about if one provider dismissed the message, did it disable it for all providers looking at the patient's record? So yeah, so that best practice alert would go away either if you ordered the consult, it wouldn't ask for it again, or if you dismissed it for the right reason. So of those reason boxes we had, if it says inappropriate or patient is not motivated currently, then it would go away for everyone because that was a good reason.
A question on that, just a follow-up question on that is there risk of, especially with the bias in treating patients with things like opioid use disorder, and that it seems like that is a risk, which it's a human factors risk, that's a risk that one person can decide, oh, this person doesn't look like they have an opioid problem, and just dismiss it.
Yeah, I think the bias was probably worse before this system, right? Because people were pretty doing selection bias on who they wanted to consult for and stuff. So when we looked at when we looked at it, we actually did see a distribution shift in who was being consulted on. It was actually the AI classifier moved to more if you look at the paper, to more consultations in folks who are uninsured, Medicaid, and a more kind of minority groups, in fact. And it actually happened later in the hospitalization too, because it kept nudging people, and usually people just do it in the beginning and forget about it. This kept reminding people, and so there were more consultations happening later in the hospitalization, which closer to discharge, which may have affected the readmission rate. So I think there's still potential for bias, like you mentioned, Christopher, but we think that because it was a systematic kind of nudge, and it wasn't, the model was trained in a fair way, it was better than the previous bias of individuals deciding who and when, right? And so, but yeah, someone could still go and dismiss it by their own bias. But I think the reason we were trying to give was trying to be something that was a little bit more objective.
Thank you.
Sure.
Go ahead, Tyler.
Yeah, thanks so much for this awesome presentation. It's really cool. I just had a quick follow-up question on the EHR workflow, the BPA.
Mhm.
Did you all integrate any sort of the explainability features into the BPA so like a provider could sort of backtrack, or is that sort of talked about?
Yeah, so this explainability thing, we built it and then it never got put into practice because when we wrote this BPA up and we went to get user feedback on it, people weren't asking for the explainability, which was a little bit surprising to us. And then the engineering work to kind of get that built in, we just didn't end up doing it. But I'm not quite convinced just yet. I feel like we should give that transparency and explainability, but we did not do it here. We did it in retrospect and kind of evaluation for our committee, governance committee, to show them what the BPA was, what the model was catching. But I think we need to go revisit that. So it's a great question. In my opinion, I think we should provide as much transparency as we can to our AI applications.
Yeah, that totally makes sense. Thanks so much.
Sure.
I see a question from Lee Kwong from New Jersey. Do you want to unmute and ask?
Sure, thank you. This is a great presentation. I really like it. I don't have much experience with AI, and then this is fascinating. And I just ask question from the perspective of modeling, because model really based on the information you collect. The more information you collect, the better the model, right?
Yeah.
So I'm wondering, when you were doing this, do all the providers in the system collect the same information? Because if all of them are collecting, holistic information, that predicts the better prediction. So if
Yeah,
providing a facility, they all follow the same protocol and asking all the relevant information, and you would identify more, you would have more reliable results.
Exactly. Yeah, so that's a great question. And the reason we went to this health system in Chicago is because it was one of the few places in the country that was systematically screening every patient that came to the hospital, at least trying to. I think they had like 90+% catchment. So with that, we were able to get over 60,000 screen results out of that, and then that led to another the universal screen, and then the follow-up screening that happened from the universal screen. So these labels were built off a kind of hospital-wide screen. So now it is one hospital. So that's why we then took that trained model to a different hospital. This external validation was at a suburban community hospital. And then we also did silent testing in our own hospital before we turned it on live to make sure there wasn't drift. And we're still continuing to monitor for drift. But I think one of the strengths we had from this model training versus an LLM kind of general purpose model, right, is that it was like to your point, it was trained on a comprehensive cohort of manually screened and verified patients that using a validated instrument.
Okay. So maybe the question is that how this model perform when it's not robusted collected information in those settings. I'm just wondering how this, or maybe through this training, you may identify some robust predictors for the outcome, so they can emphasize that predictor to identify the outcome.
Yeah, so this model, by the way, had, like I said, 15 million parameters. So if among the 50,000 medical concepts, all the different potential interactions that could happen between those concepts from a note, right? So it's hard, you can't really, there wasn't any really one predictor, right? But if we looked at the list of the top 20 features in a model, and let's just say we did it, hey, let's just do a keyword rule-based approach on this and just run that, keep it simple. Why do we need a complicated convolutional neural network? We actually did that. We did an expert-derived rule-based system with keywords. We did one that was based off what the strongest predictors were. We did a simple logistic regression. This model was statistically significantly better than all those other approaches. It's in addition to not just the health system it was trained on, but other health systems where the training data didn't occur.
Go ahead, Ian.
Sure. Yeah, this is great. I had a question because you're training on a data set which had, obviously the screening, something to train on, and then the external validation, presumably that also had screening so that you could actually measure the evaluation.
Yeah.
Is there a chance that the fact of doing the screening somehow leaks information or causes additional information to be put into other parts of the medical record?
Yeah, so we verified that with that's a great question, by the way. So data leakage was a serious concern of ours because like, oh, it must be seeing the screen data. So we actually went and audited the way that the survey screens were performed at this health system in Chicago was it was built into flow sheets. So it was built into structured tabular data. And then it wasn't a templated population into the documentation notes. So when we looked at the first 24-hour of notes, we didn't see that the screen flow sheet data was being brought into those notes. It wasn't a part of the template. So we were able to at least demonstrate that.
I was just curious in terms of like, if someone sees that they screen positive, they start asking stuff, so that additional information goes in.
Right. Yeah. So I think we were able to show that didn't happen.
Okay, cool.
Right. Any other questions? Okay, well, we'll circulate the paper in Nature. I put a link to the GitHub for the Substance Misuse Data Commons dashboard, which will also share that around, and the slides, and will be on our shared drive. I'll put the recording on YouTube, and that way you can use the QR code and take a look at the synthetic data set as well. It's really appreciate you providing like the full service,
Yeah, and there's a
understanding of
demonstration.
this.
There's a 10-minute demonstration video that walks you through the whole kind of data dashboard and how we designed it and using the synthetic data. So it help visualize what this could look like for your OFR teams if the linkage could happen.
Yeah, wonderful stuff. As far as the next few sessions, I'm actually on the 28th, our next meeting, I'm going to do a synthetic data set creation demo just using the Claude AI interface. Ronald, go ahead.
Yeah, sorry for the delay in getting this question out. I was trying to think how to formulate it. I was interested to see you kind of landed where I'm suspecting a lot of the limits in LLMs and their current excitement are, where really when you need essentially more reliable results, whether they're explainable or not, that LLMs kind of have too many random failures. And I'm wondering, in getting to that point, were you able to take time to explore LLMs for any of this classification problem and see the actual differences in performance? And then I guess to more what I'm wondering is, might LLM approaches still be useful on one end on that human interface side, which it sounds like you might be headed to with the interfaces with physicians, but on that human interface side of helping people like query ultimately these models. So maybe a more determined model like the convolutional one, but also where it might actually be good for exploratory work before you've dumped your millions into the development to say, like, is this actually worth investing in building up a model?
Yeah, no, I think that's a great point. So I think we're not done with the LLM work. I think there still is potential there. I think you just have to kind of in some ways you taking some of these open source LLMs and building a smaller model that you can fine tune. I don't know if you guys have done this before, but you can quantize these models and you can do something called low rank adaptation, which is what we do in our lab to train the models on top of their foundational kind of pre-trained version. And so I think we've been making progress there. We also have a multi-agent workflow where for the alcohol screening, if we brought in the tabular data and did table to text transformation into one LLM, we had the notes into another LLM, we had that summarized, and then that summarization was then further trained on the existing data that we had and got to a final agent. That actually did better for alcohol screening, not for opioid, not for non-opioid. And so when you can do that, then you're entering this multitasking world where you can do other things with the LLM that you can't just do with a static fixed model. Now, the next thing I'll say is one thing that's really important for the group, if you guys have experienced this or not, is that do not ask these LLMs to give you probability for a disease or a case. Hey, tell me if this patient should be screened positive for opioid use disorder risk, and then tell me your probability, and then try and build an ROC curve off that route. These LLMs are next word predictors, right? They actually do prediction for the next word off their vocabulary of tokens, right? The subwords. So it's doing is giving you the probability for that next token. It's a softmax probability distribution. So across 125,000 tokens, all those add up to a probability of 1, picks the highest probability, and that's the next word that comes out. So when it gives you, it says 0.96, that's just the next word prediction. It's not actually risk prediction. Our CNN class was trained on actual risk prevalence of screen positive cases from a cohort of patients, right? And so that is true risk probability estimation. And so you can actually then do decision thresholds on that and build your sensitivity specificity. You cannot do that with these language models out of the box. You can ask it for yes, no on screen positive and give it reasoning, but please, guys, do not ask it for confidence or probabilities, because that's just it's not the intention. It's not designed for risk probability estimation. So you lose that, but you gain other things. So I think it's just a kind of a question of how are you going to use it?
Whoops. Thanks for that. And you had mentioned in that stack for essentially, it sounded like then rewriting or tokenizing the different clinical notes, that the alcohol one did receive an improvement in performance. Was that just due to a difference in how those notes were taken, like the providers or the clinic that was happening in?
I think it was because our model was trained just on notes. This multi-agent workflow, we brought in the lab data with the notes. So it had access to all the vitals and labs. So if there was blood alcohol testing done, or if there were liver enzymes or anything like that, it could use that information too.
Okay, that makes sense. Thank you.
Yeah.
See a question from Chris in South Dakota about whether you've tested repeatability.
Yeah, the reproducibility. I mean, we did some of that work in what's called external validation, and right now we're running this system at another. There's another clinical trial happening right now, another health system. So the results should be coming out soon. So I'm happy to share that when we finalize that. But if you go into clinicaltrials.gov, you'll see that it's registered at our health system, Wisconsin, and we have another health system in Chicago that's running this currently as well in practice.
A question, clarification on that. I'm looking at repeatability on the individual records. So for example, if I ran on the same EHR case 10 times, is it going to, since it is an AI, is it going to give me the same results 10 times, or have you tested that?
Yeah, good question. So for these static models, like the CNN model, yes, absolutely. For LLMs, the generative models, there is something that you set the temperature on those outputs, which is a post hoc kind of recalibration of the model. So you might get 10 different answers, right? If you set the temperature, at it's 0.5 or something like that, which means it's not deterministic. I don't know if you guys have you can't do that in the web interface version, but those who have played with the APIs or done a little bit more LLM modeling, you can change the temperature on these LLMs and get different answers every time. That's the creativity part of it. So we don't worry about that with our CNN classifier. It's a fixed model, static. If you give it the same features, you'll get the same answer every time.
Thank you.
Yeah.